down to as low as 25% during sleep. Apparently, these people are normal. In the daytime, you check their blood pressures, they are normal. In the daytime, you see their oxygen saturation, they are normal. But in the sleep, this is what can be happening to the patient. Now, what are the treatment modalities that are available for snoring and obstructive sleep apnea? Well, there's a huge lot of opportunities and treatments that are available, and we are going to just show you what exactly is the best mode of therapy and what are the other modalities which are coming up and that they are there. So first is, of course, the lifestyle change. Well, if the person is obese, reduction in weight is one of the most important things. Though it may not be totally curative, but at the same time it can help reduce the apnea-hypopnea index and the severity of the condition. Avoidance of alcohol. That is, if a person is having snoring and sleep apnea, he should try and avoid as far as possible. Avoidance of sedatives, tranquilizers and hypnotics, as I have already told, for the simple reason that they have the same effect on the musculature and the body. So we should try and avoid. Initially, there used to be postural treatment because it was seen that large number of patients, they used to snore more on their supine position than in the lateral position. So they had created wedge-shaped mattresses so the person is not able to go into any kind of a supine position. And there were methodologies where the tennis balls were, stitched at the back of the nightgown, but they are not much of use. So upper three are the ones which should be used. And this is the gold standard therapy for the treatment of sleep apnea, that is nasal CPAP, which basically means the continuous positive airway pressure system. This acts as a pneumatic splint. There's a nasal mask which is attached to a computerized flow generator. And this gives you a positive airway pressure and which does not allow the patient to have any kind of a collapse. As you can see again over here, this is the mask. Through a flow generator, pressure is given, and this does not allow the structures to fall back. For this, we have to do what we call as CPAP titration to understand that what amount of pressure is required by an ex-patient so that he does not have a problem. And this is different for different patients. So, and over a period of time, this has to be recalibrated, initially after 3 months and then after every year, so that the patient has the optimum level of pressure requirement that is suited to him to be given to him. But there is an advancement over this particular thing now, what we call as automatic CPAP. Again, this is a flow generator, but it has got built-in sensors as to understand the airflow limitations, and the moment it sees the airway resistance, it increases the pressure and the tongue and the palate is again pushed back. So this is that if the patient requires a pressure in the lateral position which is less, it can come down to a lower level, and at the supine position, if the patient requires a higher pressure, it can give you the higher pressure. So this is, but let me give a word of caution over here, and that is that auto CPAP is not a panacea. There are large number of cases, around 30%, who will not respond to it, because patients who have severe degree of upper airway resistance syndrome or obesity-linked hypoventilation, they will have erroneous kind of findings, because in resistance it will raise the pressure without really the patient requiring it, and in obesity-linked hypoventilation it will not be able to do so. So we have to pick and choose the patient. A larger number would respond, but 30% would be there who will not be able to respond. So again, the role of normal CPAP and auto CPAP remains valid equally well. Apart from that, there are surgical technologies which have been used, but over a period of last 15 years of research, they have lost a lot of ground because there's a lot of recurrence rate, and as well as they are traumatic, the initial ones. Tracheostomy can only be used as a life-saving event. Uvulopalatopharyngoplasty initially was shown to had shown a lot of promise, but now has been almost scrapped. I'll just come down to the main one, that is somnoplasty. Somnoplasty is a treatment where we reduce the snoring of a person in an OPD setting, and we don't need to take the patient into the operation theatre. What we exactly do to the patient over here is volumetric reduction of the palate and the tongue base. That is, if they are bulky in nature. Again, this is subject to the condition that it is the treatment only for snoring and not for sleep apnea. So a lot of patients who have asymptomatic snoring, that is, after the sleep study they have not shown any sleep apnea but they have snoring, these patients can be subjected to that, and I'll show you what exactly we are doing. After putting a local injection over into the part where we need this, thereafter we expose it to the radio frequency probe, and this basically, the insertions are according to the bulk. It could be 2, it could be 4, it could be 6, according to the bulk of the palate. And as a result, as you can see over here, it has receded thereafter. I'll show you again. After the local anesthetic that we introduce, this is a radio frequency which has been introduced, and over a period of small, say few days, you will see reduction in the size of the palate, increasing the airway space. Apart from that, people who are suffering with macroglossia, the same procedure can be performed over there as well. As you can see, this is a big tongue. Again, with after the local anesthetic, and the number of things can be again ranging from 2 to 6, so that there is an equal reduction. You can see there is a size reduction of the base of the tongue, again opening up the airways. But this has not been fully approved by FDA for the treatment of sleep apnea, but only snoring. So this has to be kept in mind. Well, they always say that it should not take too long. I would like to just say, but don't hurry on for the surgery, because the other treatment is far more superior, and only when the case is having asymptomatic snoring we should try that. Another major aspect that has come in front is the dental sleep medicine, because it is lot related to the structure of the jaw. So in last around 10 years, a lot of work has been done in this particular field, and I'll show you the devices that are available and why they are being used. The first thing is that if you open if you see the mouth of a person, you can see that this is a complete opening, this is a partial closure, and this is a complete closure, as you can see, with the heavy tongue and the heavy palate. So there's a role of cephalometry in these particular patients. First we do the cephalometry to see the length of the uvula, the width of the uvula, the cross-sectional area, and this is a typical cephalogram that we use, and we have basic markers as to understand the size of the lower jaw, the position of the lower jaw, and the relative position of the teeth in the upper and the lower jaw, so as to understand what is the facial requirement of a person. As you can see over here, this is an important part which I want to show for one reason, that this is a person who is markedly obese with a body mass index of 68.1. He is likely to have a severe sleep apnea, that is 68.3 stoppages of breath per hour. But look at this one. This patient is a normal patient with a body mass index of 23.3. But if you look at the lower jaw of this person, it is small and receding in nature, and you can see that he has apnea-hypopnea index which is even more higher or severer than the previous obese person. This is an almost, you can say, a person who is having a below normal body mass index, that is 17.9, and she has the same category of sleep apnea as the sumo wrestler or the obese person had. So it is important to put forward a point over here that it is not a disease only of obese patients or persons. It can be there in very lean and thin patients. So you have to ask a few questions. That is basically an important history taking, like snoring, daytime somnolence, nocturia, perspiration during sleep, morning headaches, daytime sleepiness, irritability in nature, or any amount of hypertension that is starting, memory lapses. So if we have the history positive, even in 50% of the symptoms, then we should look into this kind of a disease. So there are three kind of dental appliances which are used: the tongue retaining devices, the mandibular advancement appliances which are the most important ones. So I'll just show a few of them. This is a tongue retaining device. Here this bulb acts as basically a negative suction and keeps the tongue forward, but it is pretty unsightly and not being used anymore. This is an equalizer where it holds the uvula and does not allow to vibrate, but again this has not shown much promise. The more important things are the mandibular advancement appliances, and they are predominantly derived from functional orthodontic devices. Treatment with these devices is recommended for primary snoring and mild to early moderate sleep apnea. They are used in patients with severe patients also who refuse CPAP because of cost factors or cosmetic reasons, because something is better than nothing at all. Now, these are the few of the examples which are boil and bite type. These are pre-manufactured things where a patient can bite the thing and create his own jaw and a own structure so that it can pull forward the lower jaw during sleep. But the more important is the custom made according to the patient's own version, as I can show you over here. Now, this is the normal denture of the patient, and after the device you can see that there is increase in the space here as well as the horizontal space. So the air movement is much more facilitated. Now I'll just show you that how it is exactly acting. Now if you see, this is the vertical kind of a picture. If you suppose it in a supine position, the tongue is just opposing the posterior pharyngeal wall, and there is no movement. It's all ricocheting back. The moment a mandibular advancement appliance is applied, it pulls forwards the lower jaw, and with it takes away the base of the tongue forward, increases the airway, and you can see the patient is breathing totally normally. Now here, this is the area you can see patient without the device, narrowed airways. This is with the device, the airway has opened up. So today we have got a large number of alternatives available, though in fairness of things, it is the CPAP which still is the treatment of choice and the gold standard, but there are certain alternatives and there are many which are emerging. As far as the synopsis of this particular thing is concerned, you can see that for asymptomatic snoring and mild sleep apnea, we can go for somnoplasty, that is reduction of the base of the tongue or the palate if they are heavy. In above 2 plus upper airway resistance syndrome, moderate sleep apnea, micrognathia, retrognathia, that is smaller jaw or receding jaw, we can use mandibular advancement appliance as well. But if it is coming to moderate sleep apnea and severe apnea and all of these put together, CPAP is valid in every particular condition and is of great help in heart failure as well as prevention of stroke, gastroesophageal reflux and general quality of life. So today we have a good number of directions to come to. It's important that we give clearer directions to our patients so that they can understand that what is their problem and how can we help them.
Thank you very much, Dr. Machanda. This talk has been very enlightening for all of us and for all our students who are listening to us all over India through the IGNOU study centers and to the download equipment installed by all the hospitals. And this has been a very informative talk to all of them. And then we all got to know that the sleep apnea is such an alarming condition nowadays, and we all of us have to identify it and treat it to avoid major problems. So I had a question. Of course, I invited questions from the audience to call us up and ask their questions from Dr. Manchanda. He's expert in sleep medicine, expert in sleep disorders. So please ask them, because this is a very general topic, I think, to the interest of for all the doctors and all the medical and general public. So I have a question that what is CPAP? It's a kind of a domiciliary treatment or is a hospital-based treatment? Because we told us that we have to have positive pressure, which actually opens up the airway passages. So is this a hospital-based treatment, or it can be also done at home?
It is totally a domiciliary treatment. A patient buys the CPAP and he uses it. It is a non-invasive kind of a therapy, and the patient does not have to, he just needs a mask and a flow generator which is fixed at a pressure, or in case of an automatic you don't even need to do that. The patient has to sleep with this equipment, and once you start sleeping with it, it's pretty easy and the patient is able to feel he has no problems thereafter. It is totally domiciliary.
Dr. Asha would like to...
Yeah, I'd like to know, sir, is in Indian scenario, are people seeking your advice for snoring and this one, apart from divorce, which is...
Today there are a lot of people who are coming. Yes, when we started 12 years ago, 13 years ago it was very small, but today a sizable number of patients, they are aware, because the results themselves are very much good. So the patients are aware today, doctors are aware, the cardiologists are aware, they send a lot of cases, and there are a lot of cases who are seeking help for this thing, and they are getting the benefits as well.
Thank you. And what percentage of sleep deaths will you attribute to sleep apnea?
Well, there is no percentage level that I can attribute to it, but there is a significant number of deaths that are there because of this particular condition.
Thank you, sir.
Dr. Rakesh, like to.
Thank you, Dr. Manchanda, for a very, very nice and elucidative talk. I have a small query from you.
Yeah, sure.
That is it possible that if a person changes his habit of sleeping supine, will it be possible that he is less likely to snore and he is less likely to have sleep apnea?
Not really, because one is that you cannot determine your posture throughout the night.
Yeah, that's true.
Second is basically this condition, this particular argument is only for mild sleep apneics. So whenever the patient is having moderate or severe, he will have stoppages of breath in every position that he sleeps. In fact, for them the preferable situation is to sleep on the tummy,
on prone.
in the prone position. So the thing is that is not real great value as far as the treatment part is concerned.
No, I'm talking primarily of persons who are mild symptomatic or asymptomatic snorers, basically.
Well, even then, if they have daytime symptoms, if they have nighttime symptoms, then they should seek help.
Right. Thank you.
Thank you very much, sir. And dear friends, in case you have any queries, you can call us right now. We still have 1 minute to go. Or you can jot down your questions, and maybe Dr. Manchanda is there for next session. You can still ask your question at that time. But I think sleep medicine is a very upcoming thing nowadays, with all the call centers, drivers coming in, getting sleep deprived, driving throughout the night, disturbing the sleep pattern, and with all the lifestyle changes for all people who are working in call centers and for all the BPO offices. I think sleep medicine is the in thing nowadays, and I think it's going to be very demanding and a good subject in the years to come. You're right, sir?
Yeah, absolutely. Because the patterns of sleeping are changing, the patterns of working are changing, and ever since the advent of the artificial light, our days have been prolonged to a greater extent. And as a society, we are a sleep deprived society. We are sleeping at least 2 hours lesser than our predecessors were doing around 70 years ago.
Very right, sir. On behalf of National Board of Examinations, I would like to thank you for coming all the way and delivering such a good and enlightening talk to all of us. And students, will take a break here for 15 minutes. And let me remind you that between 5 to 6 p.m. we are also having a radio conferencing session for the benefit of DNB students who are living in Delhi. The topic for today is how to prepare for theory and the practical examination in the subject of pediatrics and orthopedics. So you can join in between 5 to 6 p.m. at 105.6 FM Gyanvani channel of the Indira Gandhi National Open University. And we'll take a break here. We'll meet you at 3:30 p.m. for our continuing session in the subject of orthopedics, the topics which I've already told you earlier. So have a tea and come back at 3:30 p.m. for our next session. Keep watching us and take care. Bye-bye.